For the first section, we are pleased to welcome Dr. Anchalee Avihingsanon. She is an infectious disease specialist and the head of medical department at HIV-NAT Thai Red Cross Research Center. She has more than 10 years of experience working in HIV and tuberculosis research. Today, her workshop is managing drug interactions in the treatment of tuberculosis. Please join me welcome Dr. Anchalee.
สวัสดีค่ะ and good afternoon everyone. So I think the treatment of tuberculosis in HIV infected patients remain challenging, and even though we have a very good drug, a good ARV, and also the TB incidence is declining, but in terms of the issue is still there, especially in Southeast Asia. And also, the most challenging one is about the drug-drug interaction between anti-TB and also antiviral therapy, so which might compromise the viral efficacy. So actually, this part was covered nicely by Dr. Tyson at the plenary section this morning. So just walk you to the case. So I have a case for you to make decision what to do with this case. He is a 42 years old male, MSM male. He just came just 2 weeks ago. So he got a bad news during the New Year time. So January 3rd, he found that he has HIV positive. He came to the clinic because he had fatigue, and CD4 cell count is just only 11, only 1%. Hepatitis B is antigen positive, and anti-hepatitis C was negative. And the viral load have very high viral load. Normal ALT, but high GGT. Chest X-ray was normal. And he reported that he had low-grade fever, abdominal pain, fatigue, and 2 kilogram weight loss for 4 weeks. So because of the high GGT, so we request him for imaging. And from imaging, found out that he has hepatomegaly with increased parenchymal liver disease. We don't know because of chronic hepatitis B or not. And also, but anyway, he has multiple abdominal lymph nodes. At that time, we think that so maybe he has an abdominal TB, but the sputum cannot be obtained at that time, and it's quite difficult to diagnose, to have a definitive diagnosis. But because of very low CD4 cell count, we just started anti-TB. 1 week later, he reported that his clinical symptom was improving, and his drug resistance came out that he has in RTI failure. So what you're gonna do with this case? Advanced HIV, hepatitis B with abdominal TB, and also primary in RTI resistant, and he is scheduled to the clinic next Monday. So what would you do? Please vote. Where is it? Oh, I'm sorry. Oh. Okay. So majority of you select DTG 50 milligram BID, right? This is so let's see whether this is the right answer or not for, I don't know how to say, for Asian patient setting. So when we have the patient in the clinic, we have to think about these 4 important areas. When to start ART, and significant PK drug-drug interaction between TB drug, especially rifampicin and ARV. And the additive toxicity associated with concomitant ARV and anti-TB, especially hepatotoxicity. For this case, he had underlying hepatitis B as well. And the development of TB-associated RIS after ART. I think when to start ART, there is no any question for this. Very strong evidence to support that ART should be started as soon as possible, especially the CD4 cell count less than 50. So early ART is significantly reduced the ACE and event and death. So we should start ART within 2 weeks, but I just would like to remind you that at this time, anti-TB is the most important. So you have to make sure that the patient can tolerate with the anti-TB before you start ARV. Otherwise, you have to stop both medications later. And also, with the CD4 cell count higher than 50, even though it's not associated with a reduced ACE event and death, but there is no harm to start ART early. And also, the patient without TB, we recommend to have rapid ART initiation. It's true for the TB patient as well. How about the PK drug-drug interaction? So the main or the key anti-TB is rifamycin group, right? And the most potent enzyme inducer is rifampin or rifampicin, following by rifampicin and also rifabutin. Because of rifampin induce multiple intestinal and hepatic phase 1 and phase 2 metabolized enzyme, P450, especially 3A4, and also UDP glucosyl transferase, or UGT1A1, and it also can induce transporter, especially P-glycoprotein. So the resulting in significantly reduce the ARV levels. So if you look here, but just remind you that the study is that showing that rifampicin have less enzyme inducer than rifampicin based on rifampicin weekly regimen, not daily regimen, okay, for this one. For daily regimen, it seems like rifampicin also have a potent enzyme inducer as well. So you can see here that it also have like a auto induction for both rifampin and rifampicin, and ARV area under the curve with any CYP3A inhibitor has effect, especially rifabutin. For example, if rifabutin used with boosted PI, the level of rifampicin will be increasing significantly. You have to reduce the dose of rifabutin. Compared to rifampicin, rifampicin reduce the lopinavir level more than 75%. Okay, so it's different. So just this cartoon that I got it from Dr. Tim Crazy. So we have this one, the ARV regimen, and this one, the rifampicin. So rifampicin inducer enzyme. So it means that increase the drug metabolism and reduce the drug concentration of the victim, like the PI or the integrase inhibitor. So just show you these slides that this systematic review and meta-analysis just confirm that the efavirenz, the old drug, the old friend, but it's still a good friend for TB. Because this data confirm that the TB drug has minimal effect to efavirenz concentration. And also with a minimal effect to efavirenz exposure, efficacy, and safety. And we have the wrong history of efavirenz using with rifampicin other than any ART. So why I was saying that although it's an old drug, but it still be a good friend for HIV and TB patients. And for this data, it support the using 600 milligram of efavirenz. So you don't need to increase the dose of efavirenz when it's used together with rifampicin. And how about efavirenz 400? So anyone use efavirenz 400? Oh, we still have efavirenz 400, right? It's approved for patients without TB right now. So if you look at the data, also, they look at the using rifampicin isoniazid with the patient with the efavirenz 400 milligram and compare drug concentration. So this one is efavirenz plasma concentration of efavirenz when used with rifampicin here, and this one is without rifampicin, and this also with rifampicin at 4 weeks, this 12 weeks. You can see that so the efavirenz 400 milligram, the drug concentration decreased, but not that a lot. So just only 9% for AUC, 15% for CMAC, and 15% for CMIN, and also 9% for AUC. So it maybe can be used together, but just remember, this is a non-TB patient. We don't know for sure whether it might be different or not. We need more data of this. And how about bictegravir? So the early study showing that the rifampicin reduced bictegravir concentration about 75%. And then they look at the study when increased the dose of bictegravir to a BID dose with rifampicin here. This is a QD dose. This is a BID with rifampicin. You can see that the drug concentration decreased significantly. So the AUC decreased more than 60%, and also C minimal decreased more than 80%. So the recommendation is that we should not use it together. Okay. And how about the new drug, the TAB tenofovir alafenamide? Although it's a broad drug between TAB and TDF, but TAB, unlike TDF, in terms of it's a substrate of P-glycoprotein, which have so the rifampicin has an effect to glycoprotein. It means that it can reduce the drug concentration of TAB significantly. But when we look at the study and look at the intracellular and active metabolite of tenofovir, we can see that here, even though TAB with rifampicin had significantly reduced, but it's still above the tenofovir concentration. So, I'm sorry. So it's about fourfold higher than tenofovir concentration. With tenofovir, doesn't have any effect to rifampicin, okay? So we can extrapolate that maybe TAB OD dose can be used. So just move on to another important drug, the dolutegravir. So Dr. Tyson just already mentioned this study. This study is called INSPIRING. And it's very, very difficult to enroll for this study. 37 sites in 7 countries, including Thailand. They have very strict criteria. For example, they included just only patients with CD4 higher than 50, and also the disseminated TB was excluded. Okay, so comparing, so the patients were randomized to get DTG 50 milligram compared to efavirenz 600 milligram. When we look at the viral efficacy, so you can see just it's typical for integrase inhibitor that decreased viral loss very quickly during the first few weeks. But when we look at the efficacy at 48 weeks, here for 82% with efavirenz and 75% with DTG regimen. Okay. And with the drug concentration, so they have drug concentration during rifampicin here, and after rifampicin, after withdrawal of rifampicin, the drug concentration is not different. When look at the side effect, I just point out one thing about the IRIS. So the study reported that they have lower risk of IRIS, but I just mentioned that this population included only the patient with CD4 greater than 50, and also disseminated or extrapulmonary TB was excluded. So I think these group, they are at a high risk of IRIS. So we need more data to see whether using integrase inhibitor have effect to IRIS or not. So this slide just show you in terms of the PK in healthy volunteer, comparing between using DTG 50 milligram BID here and 50 milligram BID with rifampicin here, and 50 milligram OD dose here without rifampicin here. So you can see that there was significantly decreasing of DTG plasma concentration with 50 milligram BID with rifampicin. It's about 20 to 30%. So this DTG rifampicin actually mean DTG concentration that here, that were 20% to 30% higher than DTG QD without rifampicin. So why they recommend 50 milligram BID when it's used with rifampicin here? So another study looked at one DTG 100 milligram with rifampicin using as a daily, not BID dose. Because they used higher dose at the beginning, you can see that the Cmax is very high. But I think the important one, we call the Cmin here because it's related to viral efficacy. But for Cmax, it's related to toxicity. So we have to make sure that the Cmin is above IC90. For this study, they show that when used the DTG 100 milligram QD as a QD dose, they have higher Cmax, but it's lower Cmin here. So this is a 50 milligram OD with rifampicin, and also this 100 milligram QD, and this here, the 100 milligram QD with rifampin, high Cmax, but lower Cmin compared to DTG QD dose here. This 50 milligram QD also is lower, but anyway, it's higher than the IC50. IC90 in this study. So the thing that maybe 50 milligram and also 100 milligram QD with rifampicin can be used, but we need more data on that. Just look at the efficacy, because we talk about the drug-drug interaction, about the plasma concentration. So how about the viral efficacy? I think for this study, they show nicely in terms of viral load efficacy. This study is from Botswana. They look at DTG regimen in patient HIV, TB, about 1,200 cases, and about 740 cases used DTG regimen, and almost 50% use 50 milligram BID. And also you can see here, they look at the TB treatment success rate. So you can see that the DTG regimen had better TB treatment response rate here. And also when look at the viral efficacy, it seems like it's not different between QD dose and BID dose. It's slightly, they report that it's slightly a higher or superior efficacy of DTG over the BID dose. But just remind you that they use a viral load less than 400. This is the slide that they compare the factor related to TB and HIV treatment outcome. So it's clearly shown here that the DTG-based regimen had favorable effect on viral load, on TB success rate compared to non-TB group and compared to 50 milligram BID regimen here. And this is not statistical significant, but it's a trend that 50 milligram OD. So maybe 50 milligram OD can be used. I think maybe it's repeat the story of efavirenz. So we start with higher dose of efavirenz at the beginning, and then later more evidence suggests that efavirenz normal dose can be used. I don't know whether it's true with the DTG or not. Just show you maybe instead of increase the dose of DTG, why don't we just ask the patient take medication with food? Because they eat, they have dinner, they have breakfast every day, right? So instead of increase the dose with extra cost. So this study look at the pharmacokinetic of DTG in healthy subjects receive DTG at 50 milligram as a single dose. And so separate with fasting here. And also here is a low fat, moderate fat, and high fat. So here is the definition of fat. So even with low fat, so the DTG concentration was higher than fasting. It's about 30% higher. So when we look at the data, that maybe rifampicin reduced about 30%, 40%. So maybe it can be compromised or overcome of rifampicin activity. And with moderate fat, it's increased about 40%, and high fat increased almost 70%. here. This study, I just show you this data is from DTG concentration here when used with rifampicin, and here with food fasting or low or moderate or high fat. I just would like to point out here and here. These 50 milligram twice daily with rifampicin. If you take with food here, so the concentration of DTG was increasing significantly. You can see here, even high fat. So it is, when compared with this, maybe it's higher than even than this. So just this slide just show you that. So anyone interested? So we are currently conducting the study because with my own belief that Asian population usually have high ARV drug concentration. It doesn't matter any class of ARV. So we have higher drug concentration, and we think that if the patient used with food, so maybe the drug concentration is high. So why we compare between DTG 50 milligram QD with food and also comparing with standard dose of DTG when it's used with rifampicin. So we plan to do it about 10 sites. It's just only in the phase 1 for the intensive PK here. It just started. We don't have the data yet. So if anyone interested in or would like to refer the patient to us. So active TB use rifampicin, and any CD4 cell count ARV naive population. So just summary, the pharmacokinetic of rifampicin and ARV start with the PI. So rifampicin decrease all PI concentration. So it's contraindicated to use together. And even increase the dose of ritonavir, but it cannot overcome the drug interaction, and also increase the toxicity, especially hepatotoxicity, and also the tolerance to the ART regimen. So we do not use together. And I think maraviroc is okay because we don't use it anywhere in this region. Just show you that it's a significantly decreased as well. So they recommend to increase the dose of maraviroc if you want to use together. How about the NNRTI? So the guideline recommend equivalence. So at this moment, 400 milligram is not recommended yet. So maybe we have to follow up more data. So, and also, we use rilpivirine a lot, but just remember that it cannot be used with rifampicin because the drug concentration reduced about 80%, okay? And nevirapine is also reduced 20 to 60%. Although they have some studies, even from Thailand and from India, show that it can be used. But nowadays, nevirapine is all drug. And DTG, just summary that, for the DTG, when used with 50 milligram twice daily, compared to used with rifampicin and DTG 50 milligram twice daily compared to 50 milligram twice daily without rifampicin. You see that the DTG AUC reduced about 50%, and C-min reduced significantly 70%, okay? And so why I think, so maybe we just use it with food or with high-fat food. And rifampicin with DTG 50 milligram twice daily compared to 50 milligram once daily alone. So you can see here that the AUC increased with this one compared to 50 milligram, and Cmin increased as well. So I don't know whether it's also increased the toxicity or not in this population. So let's follow up with the long-term data. And with the elvitegravir, it's contraindication. Raltegravir, you heard this morning from the study, so we have to use with 800 milligram BID, but for Thailand, we still recommend 400 to 800 milligram BID. And TAP, just sum up that, so when used with rifampicin, the plasma concentration is reduced almost 50%, and the tenofovir diphosphate AUC reduced almost 40%. But anyway, it's above the tenofovir concentration. So we can use together. So just would like to stop here, and would like to thank Tim Crazy for providing the slide and everything for me.